When you have that favorite piece of furniture, like a really high-quality vintage sofa,
Oh, yeah, definitely.
right, and the upholstery is still beautiful, the wooden frame is completely solid, but over years of, well, just living on it, the internal stuffing and the cushions just compact.
Right, it totally flattens out.
Exactly. It flans out entirely,
Oh,
but
right.
you wouldn't throw the whole sofa away, right?
Yeah.
You just unzip the cushion and get it professionally restuffed.
Yeah, that makes sense.
Well, today we are looking at a physiological version of that exact process, but in a highly specific, very intimate area of the female body.
Yes, we are.
We are jumping straight into the fascinating and honestly rapidly growing world of the labial filler procedure, which is often referred to in the medical world as labial puffing or labia majora augmentation.
It's honestly a stunning example of cosmetic and functional medicine just blurring together. I mean, we are witnessing a massive evolution in what aesthetic medicine can achieve, below the belt.
Right.
It's shifting from simple topical treatments to actual structural restoration.
Okay, let's unpack this.
Yes.
Because society talks constantly about facial fillers,
Very.
right? Plumping lips, defining jaw lines, restoring cheeks.
Well, all the time.
Right. But cosmetic gynecology has quietly surged in popularity, and the mechanics behind it are incredibly sophisticated. So our mission today is to demystify the science, walk through the step-by-step clinical process, and, understand the intricate anatomy behind this procedure.
It's a lot to cover, but it's so important.
It really is. By the end of this deep dive, and we're pulling from clinical guidelines, aesthetic medicine journals, expert plastic surgery protocols, you're going to understand exactly how this procedure is performed.
Well, before getting into the syringe itself, we have to understand the canvas the doctor is working on and, why that tissue requires augmentation in the first place.
Right, the anatomy.
Exactly. So we are specifically talking about the labia majora. These are the outer hair-bearing lips of the vulva. Biologically, the primary function is to act as a physical shield.
A shield for the more sensitive areas, right?
Yes, protecting the inner, more sensitive structures, like the labia minora and the vaginal opening.
So they are quite literally the body's protective sofa cushion for that area.
That's actually a great analogy.
Thanks. But just like that cushion, they can lose their internal stuffing over time. I mean, aging, the decline of estrogen during menopause, pregnancy, and of course the trauma of childbirth.
Oh, absolutely.
All of those things naturally deplete the native fat pad and the collagen in this area.
Yeah, and the mechanism behind that deflation is entirely hormonal and structural because estrogen acts as it's like a master regulator for fibroblasts.
Fibroblasts are the cells that make collagen, right?
Exactly. They produce collagen and elastin. So when estrogen levels drop during menopause, those fibroblasts essentially go dormant.
Oh, wow. They just stop.
They pretty much stop weaving new structural proteins. So without that microscopic scaffolding holding the tissue taut, and with the simultaneous shrinking of the underlying fat pads.
The stuffing disappears.
Right. The overlying skin basically deflates, which leads to a sagging or wrinkled appearance.
It makes complete sense when you look at it at a cellular level like that. But it isn't just the inevitable passage of time or, hormonal shifts. I was reading the sources, and there was this really intriguing detail.
Oh, about the GLP-1 medications?
Yes. Rapid weight loss from the new generation of GLP-1 medications,
Yeah.
drugs like Ozempic or Wegovy, is actually a major new driver for this deflation.
It is, yeah.
We always hear about Ozempic face, right?
Mhm.
Where facial fat melts away rapidly. But that systemic fat loss happens everywhere,
Right.
including the labia majora.
Right, the subcutaneous fat just vanishes.
And because the weight loss is so rapid, the skin just doesn't have time to retract,
Yeah.
leaving all this excess deflated skin behind.
Which brings us to the functional reality of this anatomical change. If we connect this to the bigger picture, this is rarely just a cosmetic concern.
Right, it's function.
Highly functional. The loss of this biological cushion causes real daily discomfort. I mean, without that protective padding, the friction of daily life becomes highly noticeable.
Like when exercising.
Exactly. Think about the direct pressure from a bicycle seat.
Yeah.
Or just the constant friction of wearing tight athletic wear during yoga or running.
And the sources mentioned it also leads directly to pain during sexual intercourse too, right?
Yes, because the tissue is losing not just its volume, but the moisture and structural protection that the fat and collagen provide.
So it goes from being just an aesthetic insecurity to a persistent, painful physical annoyance.
Exactly. It's a quality of life issue.
Okay, so if the cushion is flat, we have to figure out what the clinician is actually putting in the syringe to restuff it.
Right. So the primary, most common material used is hyaluronic acid, or HA filler.
Okay, HA filler.
Yeah. And this isn't a synthetic plastic or, a permanent silicone. Hyaluronic acid is a glycosaminoglycan.
Like a what?
Glycosaminoglycan. It's a type of sugar molecule that is already naturally synthesized by the human body to keep tissues lubricated.
Okay, so it's a natural substance.
Exactly. And its biological superpower is its ability to bind up to 1,000 times its own weight in water.
1,000 times. That's incredible.
It really is. So when it's injected into the labia, the HA polymer network acts like a microscopic sponge. It instantly pulls in local moisture, hydrating the tissue from the inside out.
Providing immediate structural support.
Yep, immediately.
And the chemical engineering behind these modern HA fillers is incredibly targeted. I saw in the sources they mentioned a product like Deserial.
Oh, yeah. Deserial is fascinating.
Right. It's formulated purely for this intimate tissue. It doesn't just contain hyaluronic acid. It includes mannitol.
Which is so important for the healing process.
Exactly. Mannitol is a powerful antioxidant,
Mm.
which is vital because the moment a needle enters human tissue, it causes microtrauma.
Yeah, that the body reacts.
And that physical trauma triggers an inflammatory response,
Correct.
creating free radicals, those unstable molecules that basically aggressively attack and degrade the freshly injected filler.
Yeah, the body tries to break down what you just put in.
But mannitol acts as a molecular shield. It neutralizes those free radicals by donating an electron to them, which stops the degradation of the HA
It extends the lifespan of the filler significantly.
and drastically reduces post-injection redness and swelling. It's brilliant biochemistry.
It really is. And then you have formulations like Nuvia Rose.
Oh, the one with the amino acids.
Yes, it utilizes a high concentration of HA, but it's enriched with specific amino acids, glycine and L-proline.
Okay, why those specific ones?
Well, fibroblasts need those exact amino acids to weave the triple helix structure of new collagen fibers, so you aren't just physically filling a void.
You're clearly feeding the tissue.
Exactly. You are actively feeding the tissue the raw physiological building blocks it needs to synthesize its own native collagen over the coming months.
So if they're injecting raw amino acids, they're essentially dropping off lumber at a construction site and telling the body's cells to start building.
That's a perfect way to put it.
But wait, if HA is ultimately natural, meaning the body's enzymes will metabolize it over, 6 to 18 months?
Roughly, yeah.
That requires returning for maintenance. I imagine for some patients, a permanent biological option would be vastly preferable to a metabolizing gel. Isn't there a permanent option?
There is. Autologous fat transfer provides exactly that permanent solution.
Fat transfer.
Yeah, this is actual tissue grafting. So instead of using a manufactured gel, the surgeon performs a mini liposuction. They usually harvest adipose tissue fat from the patient's inner thighs or lower abdomen.
Right.
Then they place that harvested fat into a centrifuge, spinning it to separate the pure, viable fat cells from the blood and anesthetic fluid. And then they inject those living cells into the labia majora.
But since this is a living graft, the body actually has to establish a brand new blood supply to those transferred fat cells to keep them alive, right? A process called angiogenesis.
Angiogenesis, yes.
I'd assume not all of those cells survive the journey before the new blood vessels can reach them.
And that is the crucial physiological challenge of fat grafting. Because a portion of the cells will undergo necrosis, they'll die off and be naturally absorbed by the body.
Oh, wow. So how do they account for that?
Well, surgeons deliberately over-inject the area by about 20%.
Oh, they overfill it on purpose.
Exactly. They engineer the procedure knowing that the initial volume will slowly settle down into the permanent desired volume once that blood supply is fully established.
That is fascinating. But fat transfer involves liposuction, which means a surgical environment, real downtime, and, a higher barrier to entry.
Yeah, it's definitely a bigger commitment.
So for those who want the ease of an injectable filler, but maybe the long-term biological regeneration of a graft, the hybrid approach is really interesting, like Dr. Haleparn's clinic.
Yes, Dr. Troy Robin Haleparn. That protocol is amazing. Combining HA filler with platelet-rich plasma, or PRP.
PRP, right.
This leverages advanced regenerative medicine. The clinician draws a small amount of the patient's own blood and centrifuges it to isolate and concentrate the platelets.
Platelets are like the body's healers, right?
Exactly. They are essentially biological first responders packed with growth factors like platelet-derived growth factor and vascular endothelial growth factor.
That's a mouthful.
It is. But basically, these proteins serve as massive chemical signals that trigger angiogenesis and tissue regeneration.
Okay, so if we look at this like a construction project again, the HA filler acts as the wooden framing of the house.
Right.
The doctor injects it first to give the labia an immediate physical shape. Then they inject the spun PRP directly into that HA framework.
Yes, and the PRP brings the foreman the growth factors.
Right, who command the body's local stem cells to arrive at the site and start laying down permanent, healthy tissue around that shape.
It's a perfect synthesis of mechanical engineering and cellular biology.
Okay, so with a complete understanding of the canvas and the advanced materials, we need to talk about the physical execution, because the actual procedure is where the true clinical artistry happens.
Oh, absolutely.
I read it takes between 15 and 30 minutes, but the preparation starts well before the patient enters the clinic.
Yeah, the pre-procedure rules are incredibly strict.
Like what?
Well, for a full week prior, patients must abstain from aspirin, NSAIDs like Advil, alcohol, and even green tea.
Wait, green tea? Really?
Really. Things like aspirin and green tea inhibit thromboxane A2. It's a lipid that helps platelets clump together, so inhibiting that process basically sends the blood.
Ah.
And in a highly vascular area like the vulva, normal blood clotting is essential to prevent massive bruising or hematomas.
That makes total sense.
Yeah.
They also have to shower with an antibacterial wash the
Right.
morning of the procedure, right?
Yeah.
To eliminate surface pathogens.
Yes, very important. Because introducing any bacteria from the surface of the skin deeply into the fascial layers via an injection that can result in profound, deep tissue infections.
Right.
Yeah, the barrier must be entirely sterile.
Okay, here's where it gets really interesting. If you are listening to this and currently cringing at the thought of a needle going anywhere near that anatomy, I mean, the pain management protocol is the most critical element. Injecting there sounds agonizing.
It does sound awful.
Yeah.
But the actual pain mitigation relies on a multi-stage, highly localized nervous system blockade.
Okay, walk us through that.
Well, first, the clinician never approaches the area directly with a needle right away.
Oh, thank goodness.
Right. The first step is applying a high-strength, compounded topical numbing cream to the outer epidermis.
Okay, so a cream first.
Yeah. And once those superficial nerve endings are silenced, the doctor administers a local anesthetic injection deeper into the tissue, usually a 2% mepivacaine or lidocaine solution.
And that's the part that actually blocks the nerves?
Exactly. Crucially, this local anesthetic is often mixed with a microdose of epinephrine.
Epinephrine, like adrenaline.
Yes, because epinephrine is a vasoconstrictor. It temporarily forces the local capillary beds to clamp down and shrink.
Oh, so it keeps the numbing medicine in one place.
Exactly. It prevents the anesthetic from washing away in the bloodstream. And as a bonus, it completely minimizes bleeding during the actual procedure.
That is so clever. So the topical cream numbs the surface for the initial pinch of the local injection, and then the lidocaine entirely blocks the voltage-gated sodium channels in the pain nerves.
You've got it. Patients report feeling, pressure and movement, but the sharp pain transmission is chemically halted.
Okay, so with the area fully anesthetized, the instrumentation becomes the focus. While a tiny, sharp 30-gauge needle can be used, clinical guidelines like the European Medical Journal heavily emphasize the use of an 18 or 21-gauge blunt-tipped cannula.
Yes, the cannula is a game changer.
Why is a blunt tube better than a sharp needle? I mean, a sharp needle acts like a microscopic scalpel, right? It just slices blindly through whatever is in its path.
Including delicate nerves and those vital blood vessels we just talked about constricting. A cannula, on the other hand, is a hollow, flexible tube with a rounded, smooth, blunt tip. The biomechanics of the blunt cannula are what make it revolutionary for safety.
So how does it actually get into the skin if it's blunt?
The doctor uses a sharp needle exactly once, just to create a tiny entry point in the skin like a pilot hole.
Oh.
Then they thread the blunt cannula through that opening, and because the tip is rounded, as the practitioner advances it through the soft tissue, it actually glides along the fascial planes.
Happily, it pushes things out of the way instead of cutting them.
Exactly. It physically pushes blood vessels and nerve bundles safely to the side rather than piercing through them.
It navigates the internal architecture rather than destroying it. That is brilliant.
It really is.
And the exact anatomical placement of this filler is a science in itself. The cannula doesn't just deposit material randomly in the subcutaneous fat.
No, definitely not.
The protocol targets two distinct anatomical depths to ensure structural integrity. One-third of the filler is placed deeply, resting right between the fibrous tunic and a highly specific layer called the lip dartos.
Right, the lip dartos. It's a thin, dynamic layer of smooth muscle cells situated just beneath the skin of the labia.
Okay.
So placing the highly cohesive filler deeply beneath this muscle layer anchors it. It provides foundational structural support from the base up.
And then the practitioner carefully withdraws the cannula slightly and injects the remaining two-thirds of the filler more superficially, directly into the subcutaneous layer.
Yes. This superficial placement acts as the plush top layer of the cushion, smoothing out external wrinkles and providing that soft, restorative feel.
Okay, so depth is one thing, but the distribution method is equally critical. I mean, you cannot simply push the plunger and deposit a single large bolus of filler in one spot.
No, that would look incredibly unnatural, and it risks the filler migrating.
So what do?
The practitioner employs a fan-shaped retrograde injection technique.
Retrograde meaning backwards.
Exactly. They advance the cannula to its full depth, and as they slowly pull it backwards, they lay down a microscopic, highly controlled thread of filler, sometimes depositing as little as 0.125 milliliters per pass.
So tiny.
Very tiny. They withdraw almost to the entry point, pivot the cannula a few degrees, advance it again, and lay down another thread.
Ah, so it creates an interlocking fan pattern.
Yes, aligned with the vertical axis of the labia. It weaves a structural matrix of filler rather than a single lump.
Wow.
Yeah.
And while executing this fan pattern, the clinician is constantly performing a vital safety maneuver called aspirating.
Yes, aspirating is non-negotiable.
Because before ever applying pressure to push the filler out of the syringe, they actually pull back slightly on the plunger, right?
Right. Which creates negative pressure, a tiny vacuum inside the cannula.
And why'd they do that?
Well, if the blunt tip of the cannula has somehow managed to breach and enter a blood vessel, that negative pressure will immediately pull a flash of red blood into the hub of the syringe.
Oh, like a visual alarm system.
Exactly. The doctor knows immediately that they are inside a vessel, so they reposition before injecting a single drop of product.
Because the filler must only go into the interstitial tissue space, never into the cardiovascular system.
Never! That's a massive safety rule.
So the procedure concludes in under an hour. The volume is restored, the anatomy is respected, and the patient is ready for the recovery phase.
Yep.
And because this is minimally invasive, it remains strictly an outpatient procedure. No general anesthesia to recover from, no sutures to remove.
But the recovery still demands strict adherence to physiological healing principles.
Right. They're sent home with a protocol of alternating ice packs, right? 20 minutes on, 20 minutes off.
Yes. The cold causes further vasoconstriction, which actively suppresses the inflammatory swelling that naturally follows the mechanical trauma of the cannula.
And for pain management, it's strictly paracetamol.
Right, like Tylenol.
Because paracetamol operates on the central nervous system to block pain signals without inhibiting platelet function. Ibuprofen, conversely, would thin the blood and dramatically increase the risk of a late-stage hematoma.
Exactly. You want to avoid NSAIDs completely, but the physical restrictions are where patients must exercise the most discipline.
What kind of restrictions?
Well, the injected HA gel is highly malleable in the first few days before it fully integrates into the tissue matrix.
So it can change shape.
Yes, subjecting that area to intense heat, like a sauna or a hot tub, can alter the behavior of the gel and increase swelling.
Makes sense.
And applying intense friction or pressure, such as heavy weightlifting, cycling, or horseback riding, that can literally mold the filler out of shape.
Wow. And I saw the guidelines around sexual intercourse are heavily dependent on the specific procedure.
They are.
For standard HA fillers, the protocol requires abstaining for about a week, just to allow the entry points to seal and the gel to integrate.
Right.
But if the patient underwent an autologous fat transfer, the restrictions jump to anywhere from 4 to 8 weeks.
Yes, because in a fat graft, the body is busy building those fragile, microscopic new blood vessels.
Angiogenesis again?
Exactly. The shearing forces of intercourse would mechanically tear those new capillaries apart before they establish.
Which would starve the newly grafted fat cells of oxygen and cause the entire graft to fail.
Exactly. It's a much longer healing process.
And this complex biological integration raises an important question, maybe the most vital clinical question of all: the absolute safety of the procedure.
Right.
While bruising and transient swelling are expected, introducing any foreign substance or graft into the human body carries severe, albeit rare, risks. And the paramount danger in any filler procedure is vascular occlusion.
Yes, this is the one we have to talk about.
If you've ever researched cosmetic procedures, this is the nightmare scenario. A vascular occlusion occurs if the injector accidentally deposits the thick, viscous filler gel directly into a blood vessel.
Right, acting like a cork.
Exactly. Or, alternatively, they might inject so much filler directly outside the vessel that the physical pressure of the gel compresses the arterial wall inward, crushing the vessel shut.
And the physiological result is identical in both scenarios. Ischemia.
Ischemia, meaning lack of blood flow.
Right. The blood flow to that specific sector of tissue is completely halted, and tissues require a continuous supply of oxygenated blood to maintain cellular respiration.
So, deprived of oxygen, the tissue rapidly becomes hypoxic.
Yes, and if the blockage is not cleared within hours, the cells undergo necrosis.
Oh, man.
The tissue literally dies, turns black, and sloughs off, which leads to catastrophic scarring.
It is a profound medical emergency. And this exact risk is why hyaluronic acid filler is the undisputed gold standard for safety in modern aesthetics. Right, because it comes with a chemical undo button.
Yes, the undo button, it's crucial.
If the clinician observes the immediate signs of an occlusion, which manifest as severe localized pain, and the skin suddenly turning a blotchy, pale white as the blood drains out, they can instantly inject a rescue enzyme called hyaluronidase.
Hyaluronidase, it's an enzyme that specifically targets and cleaves the glycosidic bonds within the hyaluronic acid polymer.
So it's a rapid chemical eraser.
Exactly. Within minutes to hours, it breaks the thick, solid filler gel down into a harmless, watery liquid that the body's lymphatic system instantly flushes away.
It just dissolves it.
It removes the physical blockage entirely. The vessel opens up, and oxygenated blood rushes back into the tissue, completely averting necrosis.
And this mechanism is exactly why navigating this procedure goes far beyond just paying for a cosmetic result.
Yeah.
I mean, you are absolutely reliant on the injector's intricate, flawless knowledge of vulvar vascular anatomy.
Oh, 100%.
Choosing a board-certified professional, a specialized plastic surgeon, a reconstructive gynecologist, or a urologist who maps out the arteries and keeps emergency hyaluronidase drawn up and ready is non-negotiable.
Totally non-negotiable.
You are investing in their capacity to manage human physiology in an emergency, not just their ability to operate a syringe.
Right. The anatomical expertise required to safely thread a cannula through the fibrous tunic while avoiding the major pudendal vessels, it just cannot be overstated. It is a precise medical intervention.
Well, we have journeyed through the deep cellular mechanics of why this tissue loses its structural integrity today. From the master regulation of estrogen to the systemic effects of modern weight loss drugs.
We covered a lot of ground.
We really did. We've explored the highly engineered materials used to restore that volume, unpacking how HA polymers bind water, how antioxidants shield against free radicals, and how spinning your own blood triggers local stem cells to build new collagen.
And we broke down the meticulous, fan-shaped retrograde injection technique that safely and effectively restores functional anatomy.
So what does this all mean? Looking at the sheer volume of data and clinical refinement dedicated to this single procedure, it points to a much broader, highly significant cultural shift in women's healthcare.
It really does. Historically, female intimate discomfort, whether it was functional pain during exercise, physiological changes post-childbirth, or simply the anatomical realities of menopause, it was overwhelmingly treated as an unspoken burden.
Just something to deal with silently.
Exactly. It was categorized as an inevitable consequence of aging that required silent endurance.
It was entirely dismissed as just part of being a woman.
Precisely. But the rapid advancement and popularity of these minimally invasive, highly technical functional treatments indicate we are abandoning that paradigm entirely.
Which is amazing.
It is. We are no longer treating these intimate physiological changes as silent burdens. We are classifying them correctly as solvable structural problems with accessible medical solutions.
And it invites us to consider something pretty profound. As this regenerative technology continues to advance, and as these conversations enter the mainstream, how will the total destigmatization of intimate wellness fundamentally alter how future generations approach their overall health, physical agency, and experience of aging?
It's a huge shift in perspective.
It really is. We are handing individuals the sophisticated biological tools to literally restore the architecture of their own comfort. You no longer have to sit uncomfortably on the hard wooden frame of that vintage sofa. You have the science to restuff the cushions entirely.
I love that.
Thank you so much for joining us on this deep dive. Keep questioning the biological mechanics of the world around you, keep exploring the fascinating frontier of modern medicine, and we will catch you on the next deep dive.